Hello, everyone. My name is Jaap van Netten. I'm a human movement scientist from the Netherlands, specialized in people on diabetic foot disease in my research and my clinical practice. And I'm joining here today with David Sutton from Bilby Shoes. David, can you very quickly introduce yourself?
Oh, okay. So I'm a pedorthist based out in Melbourne, which is the centre of the universe. And I'm involved in educating people about the in-tube pressure mapping systems within Australia on behalf of Tekscan. And I've been using in-tube pressure mapping within our facility for, since 2009. Yeah, that's about it. Yeah.
Why did you start using it?
One of the things that we're looking at, we read little samples of research about some of the positive outcomes that people were achieving. And I thought, I'd like to be in that realm too. I mean, some of the improvements was a reduction in re-ulceration by 54%. I mean, that was just mind-blowing. And I thought, I want to have a go at this. I want to see if we can get involved and improve the outcome for our patients.
Yeah, so for those people viewing who haven't noticed yet, but that's what we're going to talk about, pressure offloading, which David probably introduced in Australia, or at least on a wider clinical scale. And I'm very interested to learn more from David. So you told me that you started using it because of the research that you read, but you haven't been involved in research. You've been really applying it in clinical practice. So what did you learn from using it in clinical practice? What did you change?
Well, look, one of the first things we realised once we started using it was that it wasn't as simple as we thought it was. I mean, we used to think by putting a depression and an orthosis, by designing a shoe with a rocker fulcrum at 60% of the length of the shoe, we'd done everything. Great job, done, finished. But we soon learned that that wasn't right. There was so much more involved about timing and loadings, and we started to learn to be smarter designing of our footwear and orthosis. We started to blend high-speed and low-speed porons within the one orthosis device. We started to analyse the actual design of the shoes more so. So, for example, if someone has wounds in the region of the toe, one of the first things we do is we remove the toe spring from the shoe. Rather than, you might have seen pressure under a toe and say, oh, I'll grind something off the orthosis. Don't do that. That's your impact absorbing material. And don't change the fulcrum. That's not going to help either. But if you change the internal shape and design of that shoe by removing the toe spring, it gets a fantastic outcome. So it really did change rather dramatically our starting point, if you will, for creating a better offloading device.
And so does that mean that you're now getting quicker to the better solution, because you probably always need to pressure map it, because you still want to know if it works in this specific patient, but maybe in the past you needed 2 or 3 rounds of adaptation and changing, and now are you managing now to do it right from the start?
Look, we get quite a few that, right from the initial go, we're within, let's say we're looking for 200, we're at that 230 kilopascal mark or something like that. We're certainly very, very close to it. But there's always going to be one that you sort of look at and think, how did that happen, sort of thing. So we are never, ever going to be in a position where we don't test. Even if we do a small alteration, I still want to test, because there's also that cause and effect of that contralateral limb that we also want to understand, because a lot of the devices that we're prescribing, the compliance comes from them feeling balanced. And if we focus on just one wound or just one foot, we're missing everything else. And that's really vital that we see everything that we can.
Yep. Yeah, absolutely. And the extra time that it costs you, how much time is it costing you per individual?
That's a really good question. So look, we actually guesstimate or allow for 60 minutes for an assessment to be done. Now that'll involve us pressure mapping the original device they had, put it to one side, and that gives us a baseline. As per the DFA guidelines, they say improve by 30% or 200 kPa. I'd like to go for the round number of 200 kPa. And then we test their device. Now, we might test the device, then we've got to go out and modify it a little bit and test it again until we get the right outcome. So we allow 60 minutes for this process, and we take somewhere between 45 and 60 minutes to achieve that outcome. And that includes the client education and engagement in that process, because I think that's probably one of the biggest compliance issues, is that we start a conversation, we start an education process with them, and that's all within that time frame.
Yeah, so that was going to be my next question. So what do patients think about having to be there for 60 minutes? I mean, on the one hand, I can imagine that that's a positive because they feel that they get the attention, but on the other hand, I mean, they got more stuff to do than walk around with you and listen to you and the footwear. So how do patients react on the pressure mapping?
Look, we tell people before they come, or even the whole process, we tell them, look, the main event is the pressure mapping day when we're dispensing the final items. You will be here for 60 minutes. They're told up front, so there's no misunderstanding or anything like that. And most people are actually overwhelmed at the fact that, as you said, you've spent that much time with them just for them to get the outcome for them. And it's, again, I come back to this engagement bit of compliance. They tend to be quite thrilled that it's such an in-depth process.
And then what do you show them at the end? I mean, do you show them the recordings that you make, or do you create a special report for individual patients? What do you give patients to take home?
Yeah, look, we do both of that. So once we do the pressure mapping of the initial device, we actually have a large screen that we show that to them on. And then we modify the shoe, present our shoes with hopefully the ultimate outcome. And then we share that data with them, remembering that a lot of them have peripheral neuropathy. So if we do something for them, they can't say, oh, well, that feels better. They might say it to make you feel better, but they don't necessarily feel it. So if we can show them the outcome, if we can show them the benefits, it's about engagement. It's about starting a conversation. It's an educational tool. And yeah, we actually give them the report to take home. And we hope that engagement and education process continues when they get home, when they talk to the family, or even just simply reviewing the documents themselves. Yeah,
that sounds really good. And so I mean, it's in the guidelines, and I've obviously been using it for quite a number of years, but so I've used since 2009. You just told me. So how many clinics throughout Australia are doing something similar like you're doing?
That's a really good question. I have quite a bit of inside information from where the Tekscan systems are, but I know there's other systems out there, but there would have to be in private clinic somewhere around 30 odd clinics at least that are doing in-tube pressure mapping with the Tekscan system. I don't know with other systems. And then you've got a large number of high-risk foot clinics within hospitals implementing it, and it's slowly spreading through more and more universities at this stage too.
So actually, that's quite a positive message that you really see it spreading through Australia. I mean, we can always improve it. In the end, we want every person with diabetes at risk of ulceration who's getting footwear to get pressure mapped. But compared to 5 years ago, do you think it's doubled, it's tripled, and then what's needed to double it again?
Yeah, look, when I got my system in 2008, I was only aware of one other system in Australia. And I took over distributorship in 2017, and I think we have something like 60% of all pedorthic clinics now have in-tube pressure mapping systems. We have a large number of hospitals in Tasmania and New South Wales with in-tube pressure mapping. I mean, a significant amount. It is growing. It's growing very fast. What's the next step? I think we need to, we're at that point where possibly the tertiary education needs to now come into that, where in-tube pressure mapping is part of the curriculum. At this point in time, I don't believe it is part of the curriculum like a biomechanical assessment is. And I think that's probably the next lever that needs to be pulled to get us to that level where we got more clinics doing, and we are going to get the end of amputations in the generation.
Great. Well, that sounds like a pretty useful step. So every podiatry and every pedortics course in Australia is going to teach on pressure mapping, I assume, within 5 to 10 years. And let's see where we get from there. David, I think that's it for me. I've got a clear overview of what you're doing in your clinic and what you're doing throughout Australia. And obviously, the next step is then to rule the world. Just from my perspective in the Netherlands, we're also busy doing the same, but yeah, we're struggling similar. I think the struggles are similar. So we're getting it implemented, but it needs to grow. It needs to grow much bigger. And there's so many countries where there's not so much pressure mapping yet available. So that's probably the next goal. But yeah, let's first try and end these avoidable amputations in Australia. I'd like to thank you very much, David, for this interview.
And thank you. Yep, really appreciate your time.